Pediatric Emergencies, Part 8. In this lecture, we're going to discuss toxicologic and fever emergencies, along with psychiatric and behavioral emergencies. Toxicologic emergencies. Toxic exposures account for a significant number of pediatric emergencies. They can take the form of ingestion, inhalation, injection, or application of a substance. In the toddler or preschool age child, they're most likely to have an unintentional exposure. Ingestion tends to involve small quantities of a single cleaning product, cosmetic product, or plant, or a few pills. Adolescents, typically these are the result of recreational drug use or suicide attempts, often involve multiple agents. Greater morbidity and mortality in adolescents, though in small children, the toxic effects of some medications are such that one pill can kill. These are examples of the lethal dose of different types of pills. And a lot of these pills are common pills that would be laying around the house. That's why it's so important for pediatric patients to not be able to get their hands on and open up these pills. The assessment of a toxicological emergency involves evaluation of the scene, keeping your eyes open for any potential clues, identify agents to which the child was exposed, the quantity and the route and time of exposure. All of these are very important questions. Findings of the physical assessment will vary widely based on these factors. Also note vital signs, pupillary changes, skin temperature and moisture, and any unusual odors. Information may allow you to identify a specific toxidrome, and a toxidrome is a pattern of signs and symptoms that are often typical of a particular poisoning. A glucose check is important because ingestion of some common substances can lead to hypoglycemia. And in this case, you would treat the documented hypoglycemia. If the child is in stable condition without physiologic abnormalities or serious toxic exposure, obtain additional history on scene using sample and perform secondary assessment. So ways to look for different toxidromes would be through mental status, pupillary changes, skin, color, temperature, gastrointestinal activity, abnormal odors. Children with potentially life-threatening toxic exposures may be asymptomatic on your arrival. The dose in accidental toddler ingestion may be very high, and you may not start seeing these signs or symptoms until the child actually starts metabolizing these toxic doses. Collect any pill containers or bottles and transport them with the patient to the hospital. As far as management goes, begin with supportive care in your ABC, D, and E's. Other options include reducing absorption by decontamination, enhancing elimination, or providing an antidote in the rare case that an antidote is available. Pay special attention to risk of environmental exposures for yourself and your crew. In the case that you are exposed, this may also require decontamination measures. If you're unsure about the exposure, there's a resource available called the National Poison Center Hotline. It's available 24 hours a day, and it is a very useful resource. Decontamination. With skin exposure, remove all clothing and wash the skin. With ocular exposure, immediately wash out the eyes. For ingested toxins, there's a couple of options to reduce gastric absorption, including dilution, gastric lavage, and activated charcoal. Depending on the substance, it may be useful to dilute the substance with a glass of milk or water. Decide in conjunction with poison center or medical control physician or nurse, depending on your protocols. If the child has any airway or breathing concerns, do not allow the child to drink. Serpa-Ipecac is no longer recommended by the American Academy of Pediatrics. It does not remove significant amounts of ingested toxins, and it can cause prolonged emesis. Do not use in the pre-hospital management of pediatric toxic ingestions. Most common method for GI decontamination in the ED setting is activated charcoal. For substances that are renally excreted, diuresis may be beneficial. Examples of times where dialysis may be required includes overdose of salicylates, lithium, methyl alcohol, ethylene glycol, or barbiturates. If inhaled, assess the respiratory status. Bronchodilators may be needed for bronchial irritation and bronchospasm. Monitoring of oxygen saturations and intubation may be necessary, particularly with inhalational injuries associated with house fires. With soot in the upper airway, stridor or swelling of the upper airway, early intubation is also indicated. Carbon monoxide inhalation injuries may be difficult to diagnose because oxygen saturation levels will be near 100%. Cathartics are sometimes combined with activated charcoal. Cathartics such as sorbitol or magnesium citrate are used. These work by speeding up elimination, and in general, they're not recommended for young children. They're known to cause significant diarrhea with serious, sometimes life-threatening electrolyte abnormalities. There are a few antidotes, and these can be life-saving. Some examples of your common antidotes: oxygen for carbon monoxide, atropine and pralidoxime for organophosphate poisoning, sodium bicarbonate for tricyclic antidepressant overdose, naloxone for opiate overdose, glucagon for beta blocker overdose, calcium for calcium channel blocker overdose. Glucagon has been shown to be effective in calcium channel blocker overdose as well. Flumazenil for benzodiazepine overdose, and N-acetylestine for acetaminophen overdose. Fever emergencies. Fever is a common pediatric complaint, but often not a true medical emergency. It's usually a symptom of an underlying infectious or inflammatory process, but the fever can have multiple causes. Most are caused by viral infections in children. They're often mild and self-limiting, but sometimes they're a symptom of a more serious bacterial infection. A general impression and primary survey will help you determine the severity. Be sure that you are asking the questions that are going to be important to get you the information that you need. You need to record the temperature, although the height of the fever does not reflect severity of illness. With young infants, rectal temperature is the most accurate. Recognition that fever is present is more important than the exact temperature, however. Look for signs of respiratory distress, shock, seizures, stiff neck, petechial or purpuric rash, or a bulging fontanelle in an infant. This may tip you off to the presence of pneumonia, sepsis, or meningitis. All can be life-threatening and require prompt transport. Young infants younger than 2 months should always be considered at risk for serious infection when they have a fever greater than 100.4, and this may be the only sign of a potentially life-threatening illness. Regardless of how well the child looks, assess and transport quickly. All children younger than 28 days with a fever and most children younger than 2 months of age will require admission to the emergency department. History taking and secondary assessment will help you to determine the underlying cause of the fever and the severity of the illness. You should perform on scene if the child is stable. If the child is seriously ill, you should perform a history taking en route, but you want to make sure that you always have a caregiver or parent close by. Fever emergencies may require little intervention. Supportive care is mainly what you're going to do. In some areas, you may consider acetaminophen or ibuprofen. However, this is important. Aspirin is not used in children. This is linked with Reye syndrome, a rare illness that can cause cerebral edema and liver failure. Limit other cooling measures to undressing and transport to an appropriate medical facility with ongoing reassessment for clinical deterioration. Psychiatric and behavioral emergencies. As a paramedic, you will encounter children with behavioral and psychiatric problems, including out-of-control behavior or suicide attempts. EMS calls for behavioral emergencies are increasing, and of children between 13 and 18 years old, 21.4% either currently or in their life have had a seriously debilitating mental disorder. Problems begin as simple complaints not recognized by healthcare providers. When not treated properly, such problems usually persist into adulthood. Medical professionals have given increased attention to mood disorders, anxiety, and other behavior problems in this population. Suicide is the second leading cause of death in adolescents and the second leading cause of death in children between the ages of 10 and 14 years. Children also are more likely to have coexisting problems such as attention deficit disorder, hyperactivity disorder, conduct disorder, and oppositional and defiant disorder, along with the more traditional mental health disorders. Safety is always your first priority. Assess the scene for the safety of you and your patient. If weapons are involved or you cannot determine the degree of risk, call for law enforcement for backup. Approach the child calmly and explain you're there to help. Address the patient directly when obtaining history. Explain what you're doing and why. Some children are flight risk, and you need to determine how best to deploy your squad so the child does not leave the scene. Some children must be mechanically restrained. This may be a task for EMS or law enforcement. You should carefully document the reason, keep restraints in place until arrival at the ED. Most importantly, remember that this is a Category B intervention, so you want to be sure that you are online with medical control. Mental health problems in children are difficult to diagnose. The lines between normal and abnormal behavior are blurred in this population, and diagnosis and treatment may be difficult when you try to distinguish among the causes. And the causes include organic, genetic, and environmental. Cultural and ethnic factors also blur the line between normal and abnormal coping mechanisms. The mental status assessment is similar to that of an adult, but also considers the child's developmental level. Abnormal findings are often related to adjustment disorders and stress. Your assessment of any child must always include a suicide risk. The pediatric assessment triangle will give you a general impression of the mental status and cardiovascular stability. A child who has attempted suicide by ingestion may have life-threatening medical complications that take precedence over the psychiatric concerns. In the absence of acute medical issues, the bulk of your assessment will be based on observation and history. In cases involving an agitated child, hands-on assessment may be limited. Treat problems or injuries with standard protocols. This concludes Part 8 of the Pediatric Emergencies. If you have any questions, please contact me at nickray@suscc.edu.